So I will today talk about temporal bone anatomy because this is a challenge for young residents as well as junior consultants, and including me. And also I will talk about not the whole pathologies of temporal bone because it's a vast subject. I will just talk about some cases, and I will show you how to approach these cases and how do I approach these cases. So today agenda is, as I said, I'll talk about imaging protocols, how we image temporal bone, and then normal anatomy, and then some cases. So we should know that CT and MRI are complementary for temporal bone. There is some information that we get from CT, and there is some information we get from MRI. So sometimes we need both to answer the question in the clinical history. For example, CT is good for bony anatomy. So CT is better for that, and we can look at the bony labyrinth and bony structures like ossicles. And MRI is good for cranial nerves like facial nerve pathway and perineural spread of disease. I'll talk about in next coming slides. So what imaging protocol? So again, advantages of CT. CT, we can look at the middle ear ossicles very easily, Malleus, incus, and stapes. And CT gives us a high spatial resolution because we can have in our hospital 0.5 millimeter thick slices in bone algorithm. And CT is short and quick. It's cheaper than MRI. Patient, there's no motion problem because MRI is longer acquisition. And again, excellent bony details on CT scan. And we can look at the bony erosions, the pathologies which erode the bone easily on CT scan. So as I said, we have a 0.5 and 1 millimeter thick slices in our institution. I have seen 0.1 millimeter thick slices as well for the research purposes in the West. And we do bone window algorithms to look at the bony anatomy easily and sharply. And we don't use routinely contrast for temporal bone CT. So there are some dedicated views for temporal bone. So one is partial view in which we actually take the plane parallel to the superior semicircular canal, and then we take images cut through this temporal bone perpendicular to the long axis of the temporal bone and parallel to the axis of the semicircular canal. And we get this kind of images here. You can see the superior semicircular canal in detail. So if there is any calcification in the canal or if there's any erosion in the canal, you can see easily. Another view is Stenberg's view, in which the axis of imaging is according to the parallel to the long axis of the temporal bone. And we can see the detail of the temporal bone easily, like this is a cochlea, basal turn, this is a vestibule, and then we have a mastoid process, and we have space semicircular canal here, tegment tympani here. And also you can reconstruct in different planes if it is present on the DICOM. And for example, in this case, we rotated the image in a way that we can see the facial canal easily. So this is a facial nerve canal going outside through the style of mastoid foramen here. So you can play with it if you have multiplanar reconstruction facility on your DICOM. So starting with CT, so we acquire images in axial plane, and then we reconstruct in the coronal plane. So now is MRI. Advantages of MRI is that we can look at the cranial nerves easily. We can start from the brainstem. We can look inside the internal auditory canal, and as well as in the facial canal through the temporal bone. And we can look at the membranous labyrinth, including vestibule, saccule, semicircular canals. We can look for any disease which is going to the brain. And we can also look for perineural spread of disease in case of head and neck cancers. In our institution, we have 1.5 and 3 Tesla MRI, and we can go down to the slice thickness of 2.5 millimeter or 3 millimeter thick slices. And we use gadolinium with our temporal bone MRI. So routinely we do T1, T2 plane, inversion recovery sequence, T1 post-contrast, and diffuse mirrored images. And then on top of that, we, as a special part of ISE protocol, like internal auditory canal protocol, we use Fiesta images. Fiesta images are high resolution, highly T2 weighted sequences in which you can see the cranial nerves very easily. Like for example, in this case, you can see the abductor nerve very easily. So these are the abductor nerves. And also we do short FOV, T2 high resolution, and T1 pre and post contrast images as well to look for pathologies in the temporal bone as a part of ISC protocol. So anatomy, a little bit, and embryology is that the malleus and incus arises from the first pharyngeal arch, and the stapes and the stylo process arises from the second pharyngeal arch. And temporal bone is composed of multiple subsegments. For example, the zygomatic process, tympanic segment, styloid process is part of temporal bone. Mastoid process is part of temporal bone, and squamous is also part of temporal bone. And also, the petrous bone is also part of temporal bone. So temporal bone, for the purpose of this talk, I'm dividing into external auditory canal, middle ear, inner ear, and petrous apex. So you can see the red line dividing the external auditory canal from the middle ear, and the yellow line is dividing the middle ear from the internal ear. And the star is basically the petrous bone. So going through the anatomy, so this is a coronal image of the temporal bone. You can see that this is I start from the external auditory canal. So this is mild swelling in the external auditory canal, and then we don't see tympanic membrane usually unless it is thickened by the disease. And then we can see this middle ear cavity with have ossicles in it. So this is a handle of the malleus which is attaching to the tympanic membrane. Then there is an incus ice cream cone sign. And then in the next slices, I'll show you stapes. The important point here is that this is a sharp bony projection from the mastoid tip, which is called as scutum. So it is eroded in the cholesteatoma. I will talk about it in next slides. And then the space between the middle ear ossicles and the scutum is called Prusac space. So in the pars flaccida cholesteatoma, this space is occupied by the soft tissue mass. And then as we go inside, we see here that there is a cochlea, and this is a cochlear promontory. And then there's in the next slides, I will show you, this is a lateral semicircular canal coming up. This is a superior semicircular canal. And then facial nerve is just below the lateral semicircular canal here. Again, scutum, cochlea. Now we can see the internal auditory canal as well. And this bony covering of the mastoid is called mastoid, tegment tympani and tegment mastoidium. And the middle ear is also divided into the epitympanum, mesotympanum, and hypotympanum. The one above the scutum is epitympanic recess or epitympanum, and then this is a hypotympanum below the level of external auditory canal. Some more images you can see. I think we can see the stapes here going into the oval window here. This is a very small bone which we can barely see sometime. Now coming to the axial images. So this is a superior semicircular canal, and this is the mastoid air cells. So we're going down again, superior semicircular canal. And now we can see the internal auditory canal here as well. And then this is a bony path here for the facial nerve going into the first geno of the facial nerve. And we can see the vestibule here. We are seeing the semicircular mastoid air cells here. And then you can see that this is a lateral semicircular canal. It's giving bony projection into the middle ear cavity. We start seeing middle ear ossicles here, mastoid air cells. And then you can see that this is a facial nerve canal going back into the tympanic segment of the temporal bone. And this is a cochlea, basal turn of the cochlea. And this is the internal auditory canal. And then now you can see the modulus of the cochlea. So this is a clover leaf-shaped cochlea which has modulus in the center, and this is a internal auditory canal. The vestibulocochlear nerve comes here, and the cochlear part goes here into the cochlea. And this is a vestibule. The vestibule part go here. And this again, we can see the thin line is hypodense line is facial nerve canal, in which facial nerve is going through. And it goes underneath the lateral semicircular canal, which I showed you on the coronal images. And then you can see the nice ice cream cone sign with incus and malleus, head of the malleus, that we want to see every time when we see the temporal bone. So again, we are going down. More images on the facial nerve canal, cochlea, modulus, internal auditory canal, vestibule, ice cream cone sign with incus and malleus. Still, we are seeing the facial nerve canal here. We are seeing ice cream cone sign, vestibule, cochlea, modulus, internal auditory canal. And now we are seeing this vestibular aqueduct. So this is aqueduct which should be wide as any semicircular canal. So this is also important bony landmark. We can see the vestibular aqueduct here, and it is as wide as this semicircular canal. So it is a normal finding. And this is a basal turn of the cochlea. You can see here. We are starting to see stapes. So this is a small stapes you can see here going to the oval window. And now the facial nerve is going down vertically. So now you are seeing this facial nerve like this. And it will exit through the mastoid process through the stylomastoid foramen to the parotid gland. Again, we are now in the level of hypotempanum. This is a hypotempanum, sinus tympani, and facial recess. And this is a facial nerve going down, basal turn of the cochlea. And we can see the handle of the malleus here and attached to the tympanic membrane. So starting with the external ear, I'll start with the first case, 52 years old man with astrocytoma on treatment, developed fever and ear discharge. So you can see that we have axial CT images of the temporal bone in the bone window and soft tissue window. So we have external auditory canal swelling, but also we don't see normal anatomy of the middle ear that I showed you just. There are no ossicles here, and there is diffuse disease process involving the entire skull base in the masticator space, involving the bones, internal ear, middle ear, petrous apex, all the way going to the foramen rotundum here. So it's like diffuse process going on, and it's causing erosion of the bones, and it's not respecting the boundaries of the anatomy. So it is basically an infection of the skull base called as malignant otitis externa. Some more images on the bone window, soft tissue window at lower level showing the involvement of the temporomandibular joint, the sphenoid bone, greater wing, the pterygopalatine fossa, the pterygoid plates, the mastoid cells, external ear, internal ear, and erosion of all the ossicles. And after 1 year, the disease actually getting worse over time, and then more erosion of the skull base, no normal, and extending all the way to the clivus and nasopharynx, and involving the masticator space, no normal anatomy of the temporal bone. So it's a kind of aggressive disease which is not respecting the normal anatomical boundaries. So it is suggestive of malignant otitis externa. So on pathology, it showed that the patient was infected with Pseudomonas and it was sensitive to imipenem. So as I told you that malignant otitis externa can go to anywhere in the skull base. It can involve infratemporal fossa, nasopharynx, parapharyngeal space, TM joint, middle ear, and ear structures, and can go into the brain as well. And it can lead to cranial nerve palsies, and it causes bone erosions, as we saw in this case. And it can also lead to venous sinus thrombosis. This was also there in this particular case. Next case is a 4-year-old female with the right ear pain for 6 months. So as a complementary case to the previous case, so now there is a soft tissue mass actually in the external auditory canal going into the middle ear and inner ear, no normal ossicles, no normal anatomy, lot of permeative changes in the bone, but there is a soft tissue mass. And then you can see that there's a normal fat anteriorly. And there's no problem with the venous sinus thrombosis as well. Again, soft tissue mass in the external auditory canal going into the middle ear and inner ear, but the fat is clean, superiorly and inferiorly, no intracranial extension. On MRI, it was again soft tissue mass occupying the entire temporal bone, mastoid process, as well as the inner and middle ears. It's showing diffusion restriction, contrast enhancement, but no intracranial extension, and normal fat anteriorly and posteriorly. So it was basically a carcinoma. So the way between how to differentiate between carcinoma from malignant otitis externa is that basically the malignant otitis externa does not respect the boundaries, and also the fat is your friend. Fat is usually clean around the tumor, but it's not as clean as in the infection. Now coming to the middle ear, we have 36-year-old female with right ear pain and discharge for 3 months. So this is a case of simple automastoiditis in which we see there is a soft tissue attenuation in the epitempanum and mesotempanum, but there's no erosion of the ossicles here. And there is a diffuse thickening of the middle ear as well as the external ear. Acute automastoiditis. So it's a bacterial infection in children usually. Next case is 31 years old woman with active complaint of off and out foul smelling discharge from left ear for 2 years. So it's been there for a while. So now you can see that, as I told you, the scutum should be sharp, but there is no scutum here. There is a soft tissue fullness in the epitempanum and Prusak space, and there is also erosion of the adjacent ossicles. And there is a mass effect on the ossicle, so it is suggestive of cholesteatoma. Basically, there are three features of cholesteatoma. One is erosion, mass effect, and soft tissue attenuation. And pars flaccida cholesteatoma is more common than the pars tensa. And it can erode adjacent structures such as facial nerve or cochlea or semicircular canals, and they can cause symptoms. And MRI is very important for recurrent cholesteatomas. Next case is 32 years old male with intravenous drug abuse. So there's a infection, abscess in the temporal lobe. On further imaging, it was found out that the patient had mastoiditis. And you can see that there's erosion of the tegment tympani here and tegment mastoidium. So infection went into the brain through this infection. There is peripheral enhancement, and there is meningitis going on with vasculitis in this patient. So patient had an angiogram for mycotic aneurysm, which was laterally coiled by the neurointerventionalist. This is the coiling in the distal part of the ACA. The next case is 40 years old female with nasopharyngeal carcinoma looking for disease progression. So this is the nasopharyngeal carcinoma in 2014, which was treated with radiation therapy. And now there is a master diffusion, which is showing some enhancement. But there's no diffusion restriction at all. So it was just post-radiation changes in the master process. So it's not any mastoiditis or anything. Next case is 58 years old female with hearing loss in left ear, tinnitus, vertigo. So this is again a temporal bone CT with soft tissue attenuation in the middle ear. But you see that this mass is engulfing the bone rather than destroying the bone. Again, this mass is not causing any mass effect on the bone, not causing any erosion of the bone. So it was basically glomus tympanicum, which is a kind of paraganglioma which arises from the Jacobson nerve. And also, if this paraganglioma goes to the jugular fossa, it can cause glomus jugulotympanicum. So just like in this case, on the left side, the mass is extending into the jugular fossa. As you can see, the jugular bulb on the right side. And here, there is in the middle ear cavity, there is also enhancement. So it's a mass in the tympanic cavity as well as in the jugular fossa. So it's a jugular tympanicum, glomus jugular tympanicum. And you can see in the coronal plane that there's a long segment lesion in the jugular fossa as well as the tympanic cavity. 9 years old girl with lytic lesion in the temporal bone, destroying the normal anatomy with enhancement on the post-contrast sequences showing diffusion restriction. And T2 intermediate signal, it was a LCH in temporal bone in a young patient. So now coming to the Peters apex. So this is a patient with trigeminal neuralgia on the right side, 41 years old male. And a patient has a lytic lesion on the right temporal bone. You can see lytic lesion on the right temporal bone, Peters apex, and following the CSF signal on all pulse sequences, T2 bright, T1 dark, and no contrast enhancement, and expressing on the flare sequence. So it was basically a Peters apex cephalocele, which can be causing trigeminal neuralgia because this lesion is communicating with the Meckel's cave where the Gazarian ganglion resides. Last case is headache and vision loss for 28 years old woman, GCS normal. So this is an aggressive lesion with internal arcs and wells of calcification at the Peters apex, you can see here. So it was a Peters apex chondrosarcoma. So these are basically arising from the petrooccipital synchondrosis, and they are off the midline, and they have local extension of disease. Thank you very much. Right side. Thank you very much. Any questions? I'll take questions later on.